Hi, good afternoon, everybody. My name's Jane Snook. I'm one of the Care of the Elderly consultants, and I manage our hip fracture unit. And I've previously done quite a lot of work with the community teams regarding the peace documentation. And so I'm just going to run through that with you today. So this presentation was very nicely put together by our ePut and St Clair's hospice team. And so I've kind of borrowed it. But I was involved in the discussions when we were putting this together. A peace document is a really, really useful thing. It's really there to help us manage our very frail patients towards the end of life. It is an advanced care document, and it means that often we have conversations in hospital but don't always have all that information sent out to the GPs or for the care homes. And so this document enables us to do that and to make sure that the communication's a lot better between the different systems. My aim today is to help you understand a bit more about the peace document. I don't know if anyone on the call already knows a lot about this. If you do, please let me know. And as we go through, if there's any questions, I should be able to see hands, so I'm very happy to answer them. The other aim is to identify when to use the form, understand what guides our practice, to help sort of develop skills on how to use it, and really the main thing about peace is the communication we have with the patient if they're able to, or with their relatives, and how we then document that to make sure the patients get the right care and that we're not constantly giving them very high intensity treatments that are causing them pain or suffering. Could you move the slide on, please? So what is PEACE? So basically it stands for Proactive Elderly Advanced Care Plan. So it's quite a complicated name, but PEACE sounds much easier. And that's really what we're trying to do, is we're trying to leave people in peace, not put them through lots of sort of really quite difficult procedures and tests that aren't going to change their outcome and may just cause them harm. I use it quite a lot in my practice here for those patients who come in who've been in recurrently with, multi-organ disease, especially those with end-stage dementia. Often we'll see them in the emergency department. They may have come in 3 or 4 times, in the last few months or a year. They're clearly deteriorating, and each time they come in, they're treated for something like an aspiration pneumonia or urinary tract infection. And the treatment seems to cause them harm. They get very agitated, the delirium gets worse, and often it feels like we're causing them more suffering than we are benefit. And then it's having that conversation with their relatives if they have dementia, to say, look, actually, what do you think your relative would want? Would they want to be put through all these treatments, or actually should we accept the fact that they're reaching the end of their life and that's the process we should be managing? And this document gives us the opportunity to document those things, like those patients who come in dehydrated because they're not eating and drinking enough. We can put down on the form that actually we accept that they're not drinking enough really for long-term survival, but we're really just giving them food and drink for comfort. They take what they want when they want, and we accept that their intake is going to be poor, and that we don't think readmission to hospital for intravenous fluids is helpful, or readmission for intravenous antibiotics is helpful. We don't want to prolong suffering. We want to give comfort, end-of-life care. There are patients who have capacity you can use these forms for. They're the sort of patients who actually themselves have expressed the wish not to have, ongoing medical interventions in hospital unless necessary. So when we do have those conversations, we document them in the medical notes in hospital, but in the past, often that's not been translated to what happens when they go back to their own home, or they go back to their care home, and a few weeks later they're back in the hospital with the same issues. So this document, which once we've completed, we can send out with the patient to the care home, give a copy to the relatives, give a copy to the GP, and then make sure it's on system 1, which most of the GPs use, will then mean that there's much less likelihood of the carers feeling like they have no choice but to send the patients back in. as it says on the bottom here, it was initially developed for using in hospital for patients going back to care homes or nursing homes, but there's no reason why it can't be used for those patients going back to their own homes. Is there anything anyone wants to ask before we move on to the next slide? Okay, can we move on? Thank you. So when should we use it? Really, this is to stop these admissions for crisis management. We should use it as soon as we feel that the patient either doesn't want the interventions we're giving. And, you know, recently I've looked after a lot of patients in their late 90s, in their early 100s, who actually are fed up of being put through medical treatments. They're tired, they feel they're reaching the end of their life, and they don't want us to keep intervening on them. And unfortunately, when they have a crisis episode, they often have delirium and so can't express their wishes. So for those patients, we can actually say, these are the treatments we are going to give. You know, if you when you go back to the care home or you go back to your own home, we can make sure you've got medicines that we can give just under the skin subcutaneously for pain, for agitation. We can manage your bowels with district nurse support and hospice support. You know, we can manage those things. You can eat and drink what you want to when you want to, but not be forced to have food and fluids if you really don't want it. We can make sure that's clearly documented on the piece, and I'll show you the form in a little while. Those conversations, the sooner they're had with the patient, then the less likely they are to end up receiving treatments that are just going to prolong suffering. The conversation obviously is the biggest part of this, and then making sure that that's properly documented. Can we move on to the next slide, please? So I've pretty much covered some of this already. It's really to provide that communication for the patient, so they explain what they wanted when they had capacity in case they lose capacity. And then for those patients with dementia, it's a conversation with their families to make sure they understand. They will often also say the same things. Oh, my mum keeps being brought back into the emergency department because she's not eating. I really don't want to do this. Is there anything we can do to stop this from happening? These are the sort of conversations we have with relatives. And say, yeah, absolutely. You know, we can put in a care plan that reduces the risk of that happening. Now, occasionally, they may have symptoms that aren't the care homes or in the nursing homes or at home can't be managed. So they may need the odd crisis admission, or if they have a fall and have a fracture that can't be managed in the home, then they would need to come back into hospital, but we can significantly reduce the amount of time that they come in and out by having the form in place. It supports the teams like the ambulance service, the care home out of hours, because, you know, as I'm sure you know, often it's not during the day that people get worse, it's that sort of middle of the night. They end up being brought in, and with the way we are at the moment, they're then sitting in an ambulance for hours, sitting in an A&E department for hours, and you know, it's just not, I don't think, what any of us would want. Next slide, please. So first of all, to complete the form, we have the conversations. First of all, you need to highlight which patients you think it's appropriate for. So I had a lady come in the other day. She was very frail. She was in her 90s. She'd actually had a hip fracture. She had so little muscle strength and she had so much contraction in her legs that actually doing an operation was not going to be in her best interest. And we normally operate on pretty much everyone with a hip fracture, so we can, you know, so we can look after their pain, even if it's a palliative procedure. But for this lady, we would have had to do a partial hip replacement, and it would have dislocated and caused her more problems. So a multidisciplinary decision was made that she was not for hip fracture surgery. She had very poor swallow, very frail, and we put in, after discussion with the family, a peace document for her to return to her care home with all care in bed, with the modified diet that she previously had, but feed at risk, and not for readmission unless there were symptoms that could not be managed. So that's how we use it. Basically, we have the conversations, we complete the form, we provide information for the person themselves if they, you know, if they are able to take it, or for their next of kin. And it's then supported by other forms we have, like the do not resuscitate order, which would also go out with the patient. They may have other care plans that they put in the past, but this particular one is really for those those sort of end of life treatments. And then if we can get it out to the GPs, they can then put it on System 1. I think our palliative care teams and ePut have direct access to System 1, so they're doing a lot of this in the care homes and in the nursing homes and in the community. They're trying to get peace in as many places as possible for the appropriate patients. We just haven't been able to really get a full grasp in doing it in the hospital, and that's what we really need to do. We were starting all of this 2 years ago, and then obviously we had COVID and lots of changes, and now we need to start really pressing on with it again as a hospital team. Normally it's doctors that fill it in the hospital. In the community we have a lot of nurses that do it, and I think we're hoping to be able to develop some of our specialist nurses to be able to do this, because I think often they're better at the conversations than some of the doctors. Can we move on to the next slide, please? So just mention about this. So any senior clinical member of staff who has training in completing the form and is used to having these type of conversations can complete the form. I don't want people completing if they don't understand it. And I've had teams come from other wards down to help them to be able to complete the form appropriately. And then it's to make sure that when they leave with it, that if they have capacity, they know it's there, and if they don't, their family know it's there. Go on to the next slide, please. So we'll just have a little look at the document itself. So next slide, please. So as you can see, it says peace at the top. There's a couple of different versions of it, but we've got one on our X drive in the end of life folder. We've decided to keep it there because it's much better to have it in one place with all the other documentation that we have around end of life care. And at the top of it, you put in the patient's details, you put in who's completing the form. So I'd normally put my name, my signature, the date, my mobile contact number, or the hospital number here, so that if the GP has any concerns or the care home does, they can get hold of the person who completed it. And then there's 4 different boxes. I don't know how big you can see it on your screens. The first one, so it says suggested action categories on progression of illness. And so we're trying to make future best interest decisions, basically. The first one is intensive. So that would be for somebody who would be for all treatment. Now, we very, very rarely use this form. I've never used it in those circumstances. But it's there in case someone wants to be able to proactively say what treatment options they would like. The second one is hospital. So it says for hospital treatment if appropriate, but not for intensive care. The third one is home, and that's so that they can be, that's for treatment, medications and comfort in their own home, and admission to hospital if you're not able to meet their needs. And then the last one is comfort, which is really sort of the last days of life, palliative input. And only then would you come into hospital if those comfort measures fail. So most of the patients that I have completed this document for have been in the comfort area. So really we're looking at for palliative care to relieve symptoms and promote comfort. And to attempt to reduce admission. I mean, as it says on there, the only time you may bring someone is, if they have a fall, they need stabilisation of a fracture, especially something like a hip fracture, because that's really difficult to look after someone without stabilisation of that. And then in the bits below, you can then write down what you think are the most likely issues that the person will have once they leave the hospital. And so in those boxes, I tend to put things like pain. A patient who's like our lady with the hip fracture, she will have pain ongoing from that. So we put pain likely because she's got a hip fracture. These are the treatments. So while she's able to take oral, she can have oral treatments. But when she's unable to take them, we have provided subcut medicines in order to support, to provide pain relief. Then because she's on pain relief, there's maybe issues with bowels, so that goes in there, and how we should treat that. And then number 3, this lady already had swallowing problems, so in that box we would put you know, if there's a risk of, you know, she's got a lot of secretions in her chest, there's hyoscine that can be given subcut or other palliative medicines. If she's not eating and drinking very much, we would not readmit her for that. It would just allow her to take what she wants when she wants for comfort, and we would expect that her intake would be poor, so that at least the home know what they're looking at. We put all of these down, and I'll show you the next page, which actually gives you much more information in a second. But at the bottom of that one, there's also about, is the patient for cardiopulmonary resuscitation? And so everybody that I have completed this form for has not been for cardiopulmonary resuscitation, and it says location of DNA CPR. So for us, that's normally that we will go with the patient when they leave the hospital. In the care home, they may then want to change that to something else, but so if the patient went home, they may have this form in one place, and they may say their DNA, their do not resuscitate orders stapled to the fridge or something, so that anyone looking at it will know where to find that form. So yeah, if you go on to the next page, please, I can just go through. So these are all the different, so I don't know how well this projects, and I'm very, very happy for anyone to have a look at the forms and then have any questions to come and speak to me. But in the what it does, it gives you a guide. So this page, I've got a copy here, so I'm just going to be looking at this because it's much easier for me to see than this one. The areas that it covers are things like feeding. So it says oral food as tolerated, involved community salt if needed. So that would be for someone at home. And then for comfort, it would be oral food and fluid as tolerated. Hydration, very similar, says low intake is very likely. So these are the bits that we can put down, but for the care home, they can also have a look at this page, because this goes with the form, and see that, oh, the patient's under comfort treatment, they're really breathless today. Rather than sending them into hospital, they can say, oh, when under breathless, it says call the GP, palliative care to consider medicines like subcut morphine, consider oxygen if you think it's going to make any difference. But normally, actually, for breathlessness, oxygen doesn't tend to make a huge amount of difference. Agitation's there, so we can give subcuts, midazolam for agitation if needed. Rule out, and you know, it says ensure no urinary retention, constipation, pain. So treat any symptoms that are easy to treat, and then give sedatives if needed for the comfort of the patient. The other areas are covered are infection. So say, you know, please don't, this patient's had recurrent urinary tract infections. We know that this causes them just to become very distressed. If they can tolerate oral antibiotics, you can put that on there, but otherwise not for readmission for intravenous. It's not going to offer them any ongoing benefit. And so for symptomatic treatment, the other things that are covered are diarrhea, drowsiness, falls, medications, talking about a medication review, and so that's something that anyone coming out of hospital should have already had. If you're on a, you know, if you're on a peace document and it is for comfort care, we should be looking at which medicines are appropriate and which are not on, you know, prior to discharge, and make sure that people go home with all their anticipatory medicines that they can use if they become symptomatic. And so the district nurses, if it's a care home, can go in, or the nurses in the nursing homes can give that, or district nurses at home. And then there's also pressure area care. So it's a really nice, this page, when you see it up close, is a really nice sort of checklist for care homes to think what should they do if the patient does start to experience symptoms. Can you go on to the next page, please? And then there's an area there that you can add any additional details, and then you would send the form with the patient. Ideally, give a copy to the family. If they're often the ones that are going up, will be going to a care home, so that will go with them as they leave, and then make sure a copy is emailed over to the GP. And then we'll also need a copy in the notes, because the patients may come back in, and if they do, you want to know what conversations have been had before, and we really need to make sure that a peace document is documented on the discharge summary, so anyone, when they do come back in, will know what was discussed and what the plans were. So if there is a crisis, they come into ED, if that can be managed very quickly, then we can actually get them back to their preferred place of care, rather than coming into hospital for a prolonged stay. Can we go to the next page, please? So when you're thinking about completing a form, it's really making sure that everyone who's looking after the patient understands why we're doing this. So, it's an MDT decision about, any areas around end of life care anyway. We always say that a do not resuscitate order is an MDT decision made with the patient or with the family. And this is a similar thing. So you want to make sure that your colleagues understand and agree with what we're doing, and then have a conversation with the patient or their relatives, or patient and their relatives ideally. When you're having those conversations, the main bits we talk about are why we don't think readmission to hospital is in the patient's best interest, why we think symptom management is the best way to go, absolutely cover nutritional needs, explain why it is that if they don't, they're not eating and drinking huge amounts, that actually that's not what's causing, we're not trying to kill them. That's not what's causing their end of their life. It's their disease process, the dementia, the end stage COPD, the end stage ischemic heart disease, cardiac failure. All of those things are taking away the person's appetite, and actually us trying to intervene with that by giving fluids or nasogastric feeding, all that's going to do is prolong harm. And all of the studies on dementia with feeding and IV fluids don't show any benefit at all, and all they do is cause us to need to deprive the person of their liberty in order to give it. When we're talking it's preferred place of death, we really should be covering this as well. Most people would prefer to stay in whichever residence they're in, or if the symptoms become too bad, look at hospice support, and then make sure that we have discussed do not resuscitate orders appropriately with the family. So I'd say that for years we've been having these conversations, but we just haven't been documenting them in a way that can be shared with a lot of people. So it may be documented in the medical notes, there may be one line on a discharge summary, but this means that in the middle of the night, the ambulance crew can actually go, look, let's not take her into hospital. Let's see what we can do to manage in the community. Can we go to the next page, please? So a lot of this I've just been through, really. What is important to this person, the patients that I was talking about right at the beginning, who have capacity and say, look, I've had enough. What is important to them, where do they want to be, what treatments do they want? That can all be put on as we would with any other advanced care plan. And what are their expectations? What's the relatives' expectations as well of what's happening when they leave hospital? We then record it and record at the bottom. If it is pure comfort care, then I always write on the form for comfort care for all elements, because if there's bits and pieces that may be hospital, then you can add that on, but just making it as clear as possible what the aim is. And so if you need any advice, I'm in the hospital here. I say, I as an elderly care consultant, I'm trying to get this across to all of our teams. In the community, there's Tracy and Fiona, and there's also the hospice helpline. So as I said earlier on, the community teams are trying to get this rolled out in as many places as possible, really to support patients. So that's a whistle-stop tour through Peace. Any of you on the call who ever asked to complete one and not sure what they're doing, please let me know, and I'm very, very happy to help. And please, any questions that anyone has, I'll very happily answer them. Kelly.
Thanks for that, Jane. It was really good. You may have picked this up already through the presentations. Apologies if I'm being ignorant. You said there'd been an alert on System 1. Is that right? Is that what I heard? So I believe
it can be put into System 1. Now, I had some training on System 1, but I don't have access at the moment. But my understanding is the forms that are being completed in the community are being shared on System 1.
Okay, all right. And do we subsequently, because I'm thinking you're right, that out of hours period, I definitely agree. Would we need wherever a care plan gets completed, will an alert be put on Cosmic? Do we know? Is that the plan? So that if anyone does present to the ED in the middle of the night, as you described, teams here would be aware.
So I'll need to check that, because I know there was an issue with the number of alerts that were coming up on Cosmic. So because the more alerts you have, the less anyone takes any notice of.
I agree with that. Yep.
Was my understanding. So they were making sure that the really high risk alerts were there. We did discuss this a little while ago as part of the sort of palliative care in this. I'll take that back and find out.
And I guess, sorry, the last question is where would we physically be able to access the care plan should someone come in? Would they come in with it? Do we know? Or
they should do.
right, okay.
That's the problem. So we really need an electronic version, and hopefully when we get our new EPR, we'll have it as an electronic version. But they should have it with their do not resuscitate order from the care home. If you think if there's something in Cosmic saying they've had one, that's just giving and they haven't come in with it, it's giving the care home a ring, a bit like we do with the do not resuscitate orders, because sometimes it says somewhere that they've got one, but we have no evidence of it.
Gotcha. Okay.
Yeah.
All right. Thanks, Jane. Thank you.
Any other questions at all? Okay, well, if anyone does come up with any questions, please let me know. As I say, I would love to get this properly rolled out across the trust. We've been trying, but obviously there's lots of other things going on as well at the same time. So please, yeah, let me know any other things. I'm very happy for this presentation to be shared with anybody, and I'm going to be doing it again for all of our Care of the Elderly team.
Thanks very much, Jane.
Thank you. All the best.